a very huge cyst that compromised our kidney functions, and we were planning to do surgery on her. 2 weeks before the surgery, she came back for pre-surgical evaluation, and she got pregnant spontaneously. So we had no choice other than to postpone our surgery and manage her conservatively, but unfortunately she miscarried at 20 weeks. So depicting the findings, according to research now, that if you have endometriosis and adenomyosis, there's a risk of miscarriage. Next slide, please. And then I have another patient, almost the same, looking at the enzyme. Next slide, please. Stage 4, she had very huge type 0 submucous fibroids. So she has severe pain. You can see the laparoscopic view on there. Very severe pain, so we had to do surgery. We remove all the endometriosis tissue, and then secondly, she had laparoscopy to remove the fibroid. Unfortunately for her, she got pregnant. When we did IVF for her after the mammectomy, and we did a frozen embryo transfer, she currently has a baby girl, and baby girl is doing well, about 6 months now. Next slide, please. So, clinical presentations, Dr. Olalere has done quite a nice job, so we are not going to waste so much time on this, but we know that there are 3 existential classifications: peritoneal endometriosis, ovarian endometrioma, deep endometriosis, and management diagnosis varies according to the type of the endometriosis the patient has got. And it's to tell you that a patient with stage 1 endometriosis, stage 2, 3, 4, the prognosis, whether pregnancy spontaneously or with IVF, or the outcome of the pregnancy, depends on the stage. So my focus will be mainly on those who have deep endometriosis, because we know from our own practice that stage 1, stage 2, mild endometriosis, mild adenomyosis is not a taboo for pregnancy and good outcome. Next slide, please. So natural history, we know a lot about natural history of endometriosis and adenomyosis. About 30% will resolve spontaneously, and 64% do progresses. And even after a year, it can become stable. Next slide, please. Okay. Diagnosis, we know the impact of ultrasound scan and MRI, and we know now laparoscopy now is not the gold standard for management of endometriosis and adenomyosis anymore. Next slide, please. So they are up to date. There are a lot of guidance online, country by country, societies by societies, but we're still scratching the real cause and the management options for endometriosis and adenomyosis. Next slide, please. This is a recent ESHRI management strategy that was published about 2 years ago. And then we have this classification, which is one of the most popular. Everybody uses it. And it's very good. It can state the endometriosis for you and adenomyosis, and it can shape your management strategy. You can diagnose it with scan, you can diagnose it by MRI, or even surgical diagnosis. It's possible. Next slide, please. Now, best management option we all know is to manage it in MDT, with surgeons, radiologists, bowel surgeon, urological surgeon, thoracic, because endometriosis is a multisystemic disease. So it's not something one specialty can manage, most especially if it's deep endometriosis. Next slide, please. Pathophysiological mechanism. Next slide, please. Pathophysiology. Whether you are pregnant or not, endometriosis is still endometriosis, adenomyosis is still adenomyosis. The pathophysiological mechanism is the same. And unfortunately, during pregnancy, we still have all these growth factors that operate. So it links adenomyosis and endometriosis together, that if you have endometriosis, these growth factors are still operating. So proliferation, apoptosis, dysregulated angiogenesis, all mediated by different hormones I shown on the slides. And the importance of this is that if you are pregnant and you still have active endometriosis or adenomyosis, this mechanism is still ongoing. And some of these growth factors and interleukins and all the other ones are still operative during pregnancy. Linking the two together and their management strategy or sometimes follow this mechanism. Next slide, please. What are the impacts of this on fertility and conception? Next slide, please. We know the pathophysiology. Why is endometriosis or adenomyosis affecting conception, causing infertility, causing pain, and preventing and causing sometimes abnormal outcomes of pregnancy? We know deep endometriosis, we know the effect of adenomyosis, we also know the effects on the endometrioma, ovarian reserve, sexual intercourse. All these have a significant impact on fertility and pregnancy. Next slide, please. So mechanism by which adenomyosis affects fertility, Dr. Lateef has done quite a nice job. So, but the important point is still that pain is an important factor. The uterine physiology and pathology is also a very significant factor. And then, of course, the hormonal imbalance that is associated with endometrioma, if it's present, can also have a significant side effects. Next slide, please. So, impact on fertility and conception. 50% of our infertile patients that come to our clinic are being found to have endometriosis. And as I said earlier on, pregnancy can occur spontaneously, and it can also be by medical-assisted reproductive technology. Early pregnancy outcomes, there is an increased risk of miscarriage. Endometriosis and adenomyosis sometimes get better during pregnancy. However, a majority of our patients with deep endometriosis, if they are not surgically treated, sometimes they do have significant outcome during pregnancy that can put them to risk of miscarriage. 1 to 4 or 1.8 higher odds of spontaneous miscarriage. Adenomyosis up to 2 times risk of miscarriage. And of course, endometriosis risk is 2 to 4 times the normal. Next slide, please. Pregnancy and adenomyosis or endometriosis. With assisted reproduction, we know that there's an improvement in the chances of pregnancy. If a patient comes to you with significant pain, and then you want to focus on the pain, we give analgesia, we give hormonal treatment. Sometimes the hormonal treatment is anti-fertility. And in that case, some of our patients do need to have medical-assisted reproductive technology, especially if they have severe endometriosis. Assisted reproductive technologies, ART, egg freezing, and IVF freezer is one mechanism that has been shown to be very effective. And of course, as we mentioned earlier, and Dr. Lateef also mentioned, individualized treatment protocols help outcome of fertility and pregnancy. Factors influencing all this include the age of the patient, health and lifestyle that will compromise fertility anyway or pregnancy, even if the patients have treatment for adenomyosis or endometriosis. All these significantly have impact on the chances of successful ART and pregnancy. Next slide, please. Freezing egg before surgery. freezing egg before ovarian endometrioma treatment has been found to be significantly beneficial, especially if you are going to do surgery. There is going to be loss of egg reserve. And in that case, a number of studies have shown fertility conservation to be very effective for the patient prior to surgery. And if you are going to proceed straight to IVF, sometimes it's better to freeze or treat the patient with down regulation for about 4 to 6 months before you go back to a free frozen embryo transfer. A number of studies have concluded that this has significant benefit in terms of pregnancy outcome and even getting pregnant on his own. Next slide, please. Next slide. So there are a number of publications, a lot in the literature, that has concluded that if you have endometriosis and adenomyosis, especially those who are at the higher stages, they do have risk. Next slide. They have significant risk of complications. And this is just a summary slide of all the articles I put down. And the conclusion is that milder forms of endometriosis most likely affect fertilization. But if the patient do manage to get pregnant, implantation processes are not appreciably affected, and sometimes most of them have significant improvement during pregnancy. Pregnancy goes on fine, but however, there is an increased chance of operative delivery, especially cesarean. And complications does not only affect the woman herself, it also affects the baby. And we're going to look into that in a minute. Next slide, please. Does endometriosis increase pregnancy risk? No doubt about it. There are a number of studies, systematic reviews, that already showed us that endometriosis and adenomyosis have adverse risk presentation during pregnancy, and outcome could be better if we multidisciplinarily manage these patients during their pregnancy. Next slide, please. Recent epidemiological research has shown increased risk of adverse pregnancy, as I mentioned earlier, including preeclampsia, small gestational for age, preterm birth, and all these share common epigenetic alterations in endometriosis and adenomyosis. I've already shown you the pathophysiology earlier on. Next slide, please. So, antenatal outcomes, this is one of the other studies that I'm showing you. We're not going to go into we're not going to go deep into this, but the fact is that with adenomyosis and endometriosis, there's increased risk of placental complications, hypertensive disorders, preterm birth, small for gestational age, and cesarean deliveries. Next slide, please. So also this slide shows. Next slide, please. Now we're talking about the baby, and there is elevated risk, miscarriage risk, increased preterm birth, increased need for neonatal intensive care unit for the baby if the baby needs to be delivered prematurely, especially, or the woman goes into spontaneous labor and you just have to deliver the baby. So it's always nice to manage them in multidisciplinary settings. Next slide, please. So, as we said, for the baby, there is also adverse maternal and fetal outcomes. This is not to say that pregnancy and outcome is bad for all the patients. And if you individualize their management patterns, some of the patients will have good outcome. Next slide, please. So we're still on the neonatal aspect, nature versus nurture. Nature, genetic predisposition for the baby. However, effect in utero can affect the baby, and we know about Barker's theories, and it's also been said that there is increased risk for the baby in herself to have endometriosis and adenomyosis. Next slide, please. And this is even after surgery. After surgery, patients get pregnant spontaneously or by medical assisted reproduction. Endometriosis and adenomyosis are progressive diseases. Sometimes surgery gives some benefits, but they still at significant risk of all the outcomes we mentioned earlier. Next slide, please. But what is important is to manage them, and we talk about MDT. Obstetricians to get involved, reproductive endocrinologists, radiologists, anesthesiologists, neonatologists, and of course counseling, psychological counseling. This is very, very significant. I know most of us, sometimes we do overlook this. Psychological effects of adenomyosis and endometriosis with or without pregnancy, with or without delivery, are very significant. And we can see, we see all this happening in our clinic, so we must be prepared for it. Next slide, please. So, must be managed in obstetric-led care, which is very important. We talk about multidisciplinary. Next slide, because of time, I don't need to. Postpartum health consideration, as I mentioned earlier, is very important. Some of these patients can easily go into postnatal psychosis if they are not properly managed. The fact that they delivered, usually maybe by cesarean section, they still have the adenomyosis and endometriosis going on, so they are prone to psychological depression during pregnancy. And this is what is coming on. The training now is to recognize this and treat it effectively. Next slide, please. So, impact on psychology of the mothers during pregnancy and after pregnancy is also very important. Please, I want us to put much emphasis on this, because trends now are showing that majority of them, soon after the delivery, we think that everything is over, but they may have some effect psychologically. Next slide, please. Support and resources are available from groups and educational resources from the clinics as well. Next slide, please. Conclusion. So, we've seen the effect of I've outlined the effect of endometriosis and adenomyosis on pregnancy and outcome, and I can show you that there are a lot of systematic reviews, meta-analysis over the last 10 years that has concluded significant adverse effects of this. But if we properly manage the MDT arena, most of them will have very good outcome. Next slide, please. Thank you so much. I think this is just to give us a summary of what I've talked about in the lecture itself. Next slide. Next. Thank you. Yeah, thank you so very much. Thanks.